We invite Dr. Jenny Gandhi for her talk.
Good afternoon, everyone.
Your intro will be given by Doctor, so please a moment.
Madam, that's okay. Can I? I will start. It's fine. So, I'm Dr. Jenny Gandhi. I'm a vascular and intervention radiology. Intervention radiology, by means of intervention radiology, we treat blood vessels of the body, brain and the limbs and the body, except heart, which is dealt with the cardiologist. So today my talk is very specific about neurointervention. I have started my practice in 2019 in Surat. It's been 4.5 years I'm practicing in Surat. I do maximum number of neurointervention every month in Surat and entire South Gujarat. I have been trained in KEM Mumbai for intervention radiology, and then for further neurointervention pursuit I went to KMCH Coimbatore, and I have spent 5 years in intervention, and then I started in Surat in 2019 in Shelby Hospital, Surat. So I would like to start my talk that neurointervention is the future of neurovascular treatment. We do all sort of treatment through a small nick in the groin, through a blood vessel, and it's not an open surgery. So what all diseases are covered in neurointervention? So we treat stroke by means of mechanical thrombectomy, critical stenosis of head and neck blood vessels, which are the root cause of minor or major stroke, that is endovascular angioplasty and stenting. Brain aneurysms, ruptured or symptomatic unruptured aneurysms which require treatments by means of endovascular coiling, flow diverters or intrasaccular devices. And last but not the least, that is brain AVM and arteriovenous fistulas. We do endovascular embolization. So first I would like to start with mechanical thrombectomy, that is for stroke. Stroke is a disease. It is not a disease of an individual, it's a disease of a family. If a earning person of a family suffers from any minor or major stroke and if the patient becomes bedridden, then the entire family suffers. Sometimes it causes mortality, the life is taken off, or if the patient survives the stroke, he or she may be bedridden and the entire family suffers behind the patient. So what if we can treat the stroke and either we can reduce the mortality, sometimes we can make the patient completely normal in a month's time, or we can prevent at least mortality. So according to the US data 2018, 87% of the stroke is a ischemic stroke. Ischemic stroke is like how people suffers from a heart attack when the coronary gets blocked. Similarly, it's a brain attack. When the blood vessels of the brain gets occluded, the patient suffers from the stroke. So 87% of the stroke is ischemic stroke. Only 13% of the stroke is hemorrhagic stroke. So today I will be focusing on ischemic stroke. So what is ischemic stroke? When one of the major blood vessels of the brain gets occluded, the patient suffers from the stroke, and the signs and symptoms of a stroke I think everyone must be aware of. Patient becomes aphasia, suddenly unconsciousness, unilateral weakness in the limb or upper limb or lower limb. So what the intervention people offer? We work in a team with a neurologist. If the patient of a stroke comes to a clinic within a window period of 4.5 hours and the CT rules out that there is no hemorrhage and it's a ischemic stroke, then the neurologist, according to the seeing the indication, they may give IV thrombolysis. But if there is a major vessel occlusion, like a blood vessel is closed from the neck or the main blood vessels in the brain, then the IV thrombolysis is not sufficient. The amount of clot burden is so high that the artery will not get opened just by IV thrombolysis, and along with IV thrombolysis, the neurologists do refer patients for a mechanical thrombectomy. Ideally, it should be done within 24 hours, and in 24 hours also it should be done as early as possible to revive the brain neurons. So how do we do? Suppose this is the blood vessel, this is the clot. We go up to the level of clot in very tiny arteries of the brain, and we suck out the entire clot. Once the clot is sucked out, the artery gets open again, and the brain gets the blood perfusion again. So the stroke effects can be minimized, or sometimes it can be completely reversed. So the procedure is called mechanical thrombectomy. It is a complementary to the neurology treatment. So here whatever cases I will be showing, it is all done in a span of last 2.5 years, rather 4.5 years in Surat. So acute stroke in 16-year-old kid. This patient was done just 21st of August. He on the left side you can see this is the MRI brain. The white area is the damaged brain parenchyma, and here there was a M1 occlusion. On the right side you can see the artery is completely normal, and on the left side there is a complete cutoff. So within this is the angiography image. Right side completely normal. Left side there is a occlusion on the left main vessel. We went up, did mechanical thrombectomy through a stent retrieval and aspiration catheter. The procedure took just 25 minutes, and the artery got opened completely. And this is the clot which we took out, and this is the patient's video. Because of the talk, I just contacted patient. It's just been 11 days and he's completely normal. He's a 16-year-old kid, and he has become completely normal, no limb weakness, no neurological deficit. Another patient, the stroke happened due to carotid artery dissection in the neck. So when patient presented initially, the thrombolysis was given. After thrombolysis, patient symptoms improved partially, but the artery did not get open, as you see on the last angiography image. But the brain was getting perfused from the opposite side here. From the right side, the left side brain vessels were getting perfused. So we did not, and the patient did not have any neurological deficit to begin with. So we did not do a mechanical thrombectomy because distally the brain was getting the blood supply. But after 1.5 days, midnight at 1 o'clock, I got a call that, Madam, since past 1 hour, patient is not responding. Neurologically on one side, right side, the power has become 0, he has become aphasic. We repeated MRI immediately in 10 minutes, and that the new infarcts were getting developed. And this was the previous 1.5 day before scan, and this was the new MRI. So we immediately came to conclusion that there is a emboli distally and it has blocked the vessel. So this is we repeated CT angiography. This all imaging usually we do in half an hour span, because in stroke the time is brief. We have to, whatever we want to do, we have to do immediately as early as possible. So there was a blockage in the main blood vessel in the brain, which was initially getting perfused through a contralateral blood vessel. So here there was a blockage here. and that we can see on this MRI also. So now it has become a tandem occlusion. One block was below because, so can you see this black area? That was the embolic occlusion of the M1 segment. So angiographically, we immediately took patient in the cath lab because neurologically he has deteriorated, and this was the carotid dissection, and there was no distal flow from the right side also. Now it was not getting filled. So, and this is the basilar artery, which was pile collaterals were also very poor. So we did mechanical thrombectomy midnight. We fixed the dissection flap in the neck through a carotid stenting, and this was the final. The artery got completely normal and open. This is the clot which we retrieved, and this is the final angiography and patient. Now the blood vessel is completely normal in the brain. This is the patient. We could save the life of the patient because of the basal ganglia infarct, which has already developed before procedure. There will be some neurological deficit, but we could manage to save the patient. Otherwise, this patient would have died in another 1 week. So, if there is a stroke, we can of course treat it. We can reduce the mortality, we can reduce the morbidity also. But what if we can completely prevent the stroke? Because we have been taught that prevention is better than cure. So there is the role of elective carotid or intracranial stenting comes. So it should be rather the stroke prevention and the role of endovascular treatment. So the majority of the ischemic stroke are either a watershed infarcts or embolic infarct due to this proximal thrombus. So in many patients we find on a health checkup or some minor symptoms on color Doppler that there is a carotid stenosis and it is significant, which is causing the repeated TIA, transient ischemic attack or a minor stroke. So we can electively do carotid stenting. How we do it? We go through a groin, through a small blood vessel, through a catheter, and we can negotiate the stenosis, and we place a stent across. This is called the angioplasty and stenting. We do in a way that patient usually get discharged in 48 hours. So this is a patient symptomatic left carotid stenosis. As in MRI, there are multiple tiny ischemic infarcts, embolic infarcts. On CT angio, there was a tight carotid stenosis. We treated with balloon angioplasty and stenting. Another patient with acute stroke with carotid occlusion, we did sometimes the patient has a double lesions like the carotid stenosis which is untreated, which leads to acute stroke. So we do in mechanical thrombectomy followed by a carotid stenting in acute setting. Another patient, bilateral atherosclerotic disease, both sides there is an infarct. So this is a left side ulcerated plaque with severe stenosis. The carotid stenting is performed. Electively, 2 weeks after, the right carotid stenting is performed. Bilateral carotid stenting. No open surgery. After each procedure, patient usually gets discharged in 48 hours. It is done in local anesthesia. No need of general anesthesia, so the morbidity and mortality is very less, and patient starts walking in 24 hours. Other than atherosclerotic disease, sometimes the patient do get, if there is a history of surgery, oncosurgeries, and if they get radiation, there is a radiation-induced stenosis also. The treatment is same, irrespective of the cause, whether it's atherosclerotic or it's a radiation-induced. The patient requires angioplasty and carotid stenting. So we can do a bilateral carotid stenting at the interval of 2 weeks. Similarly, in the neck, we find the carotid stenosis. We can have a stenosis in the brain also, which is symptomatic and which is causing the minor strokes or repeated attacks of TIA. So there also we can do a balloon angioplasty and stenting. So this is a patient, my repeated strokes were there. One side artery was completely occluded, opposite side there was a tight stenosis, and we did intracranial stenting. Another patient similarly, in case of intracranial stenosis, and stenting was performed. Another patient, this is a very deadly disease, brainstem, where all perforators comes, and there is a tight basilar artery stenosis. So the basilar artery stenting was performed, and now you can see the basilar artery is completely normal with all saved perforators. Another patient with minor stroke and severe basilar stenosis, basilar stenting. This is a patient with vertebral stenosis where pica basilar artery is getting perfused through the left vertebral and the basilar artery stenting is performed. So, like carotid and intracranial stenting, these all procedures are done without any open surgery through a small needle in the groin. There is not a single suture, either it's done in local anesthesia, and usually all patients get discharged in 48 hours. So, we can save the life of the patient through this procedure, and it is very good if we can prevent the stroke. Now, I would like to switch over to brain aneurysms. There are dictum that if there is a brain aneurysm and brain hemorrhage, then patient will not survive and they will die either in ICU or in hospital. But now it's not so. We have a minimal invasive technique where patient does not require open surgery, and we can treat such aneurysms through a minimal invasive technique without an open surgery. So this is one DACA aneurysm, distal anterior cerebral artery aneurysm. We have performed endovascular coiling, and this is post-coiling. The artery is completely normal and the coil is gone. Another patient, ruptured aneurysm. At some other centers, some neurosurgeon has tried clipping, but it failed. As you can see, this image, the clip has slipped from the neck of the aneurysm, and then he was referred for the coiling. And this is the post-coiling, aneurysm is gone and the artery is completely normal. Another patient, large aneurysm of the brain, which has presented because of the diplopia, eye symptoms. This large aneurysm compresses the optic nerve, and patient usually has a diplopia or difficulty or reduced vision in one eye. So we have performed the flow diverter plus coiling in this patient. Flow diverters are the very devices where aneurysms cannot be tackled through a simple coiling, in which the mesh-like device we put in the parent artery, and these aneurysms are not amenable with open surgery also. And the endovascular treatment is the only choice for the patient. And all patients usually get minimal invasive treatment. This is another giant aneurysm of the brain. You can see the 2 centimeter aneurysm in the brain, and the patient has received flow diverter plus coiling. No open surgery, just through a small nick in the groin. Another patient, complex aneurysm, ICA bifurcation, large aneurysm. There also flow diverter plus coiling. Blister aneurysm, where this all references we get through a neurosurgeon, because this blister aneurysms, giant aneurysms, large aneurysms, there is no way for open surgery, or the mortality is very high and the treatment is always suboptimal. So in this blister aneurysms, they are like a bubbles. They don't have even true wall. So if they try to put the clip slips, and there is no the treatment. These aneurysms usually tend to re-rupture. So before the era of 2011, when the flow diverters were not there, this patient almost mortality was 100%. But now, because of this flow diverter treatment, the results are very much drastic. And we have put the mini flow diverter. As you can see, at 1 year, the aneurysm is completely gone, and this is patient in OPD after 2 years. It's completely normal. Age is not the bar. A brain aneurysm in an old age, 87-year-old woman, ruptured brain aneurysm. We have done endovascular coiling, and this is patient after 14 days. Patient got discharged normally after the SAH protocol at 14 days. Another patient, dissecting aneurysm of the basilar artery of the brain. We have put the double flow diverters in the brain, and this is patient very next day in the ICU, in hospital, completely normal. Complex MCA bifurcation aneurysms, where the intracerebral devices are the treatment of choice. And this is the contour device which we have placed. So this is like one of its first surgery in entire Gujarat, not in South Gujarat also. We have done 2 years back. Subsequently, many cases has been done by us. So it has been covered in the newspaper and by media. Now there is other than aneurysm, we treat the arteriovenous malformations of brain also. They do either rupture and patient presents with a hemorrhagic stroke, or the unruptured patient usually has a headache or seizures. ખેંચ આવતી હોય એમને. એટલે that's how the patient gets MRI or CT scan. They are being diagnosed as arteriovenous malformation of brain. So I have been encountered similar such patient. 6-year-old kid with a brain hemorrhage. On CT there was one aneurysm was seen. But in 6-year-old kid, this aneurysm is very unlikely. Either it can be mycotic, yes, very uncommon, but it is possible, or it can be a vasculopathy. Developing brain has a tendency to develop vasculopathy. So he was completely hemiplegic. As you can see in the video, he was not able to lift his left upper limb and lower limb. We treated his brain aneurysm by endovascular technique. Then for the vasculopathy, he was on follow-up for 2 years. He has been received treatment of gamma knife for the vasculopathy, and he's doing completely normal. It's been 4 years after the patient has been treated, and he's doing absolutely normal now. Now he's a 10-year-old kid, and he's living completely normal life. And he even doesn't know that he has undergone any form of brain treatment. Similarly, 12-year-old kid, he had, like, it is difficult to identify for a non-IR doctors, but there was a small AVM here, and which has bled. This white area is the bleeding in the brain. So at 6 weeks, because we need time to shrunk this hemorrhage so that we can visualize, we can see the entire nidus of the brain. So at 6 weeks, we repeated angiography and we did embolization by a liquid embolic agent that is called onyx or squid. And this is patient at 48 hours in the hospital. He got discharged 48 hours after. And he's completely normal. I think he's in 8th or 9th standard. He has resumed his school study again. So it's not the fancy angiographic image which matters to us, but it is a normal patient who walks out from the hospital after either a brain hemorrhage or ischemic stroke, and the family has lost hope, but somehow because of the newer techniques, newer devices, and because of the neuro intervention, this all facilities, this all treatment is now possible, and we do it in Surat because I remember still, like out of 100, one patient still goes to Mumbai with stroke. So by the time they reaches to Mumbai, the window period is already gone. The neuron has already damaged. The brain is already infarcted. Even if they go into the best hospital in Mumbai, then also they have lost time. That's why the further treatment, whatever they receive, but they cannot recover the damaged neuron. So we have able to set a platform and the OT, the cath lab, ICU team, and it's a teamwork. Of course, the neurologist and neurosurgeon doesn't come in cath lab. They are the referring or the feeding doctors who send patient to us. But we are able to establish a level of practice which is similar to Mumbai, and we are able to deliver good results in Surat itself. These are costly treatment because of the devices which is used. These all devices are imported in India from either USA, Germany, or other outside India company from Japan. So these are costly devices. That's why the procedure cost is high. But the results are excellent. No one has, like I have shown you one patient, this kid, like 15 years back it was not possible to treat the patient. And now today he is living completely normal life. His father is in L&T and he is so thankful whenever he comes, whenever his birthday is there, he always send one thanks note to the hospital and to me. And this is one truck driver patient who had a dissecting aneurysm in the brain. This patient was referred to me by a neurosurgeon, and that was he had a brainstem stroke. Yeah, just 1 minute. 1 minute I'll take. This MRI, that is a brainstem stroke. If we could not have fixed this aneurysm, he would have died. But it's been 3 years and he's living completely normal life. Similarly, it's stories for every patient. This patient underwent 2 treatments, one left vertebral artery stenting and blister aneurysm for brain. So he comes on his birthday with the birthday cake that the doctor has given a new life to me. So I will celebrate my birthday in the hospital. This is another patient. This kid, I have not told you in detail he had birthday, he was cutting the cake, 16-year-old kid, and
Sorry, Jenny.
so madam, just half a minute. This is a very heart-touching story. So 16-year-old kid, just 10 days back, he had a birthday, he cut the cake and he became hemiplegic. His father was going to feed a cake in his mouth and he had a stroke. Patient was referred to me by a neurosurgeon and we performed mechanical thrombectomy in emergency at night 12 and after 10 days he is completely normal. So this is the magic of neurointervention and I think the awareness is needed, but it's a very life-changing stream and field for the neurovascular pathology. Thank you.
Thank you very much, Dr. Jenny. Now I request Dr. Dipti Patel and Dr. Trupti Patel to felicitate Dr. Jenny Gandhi.